just to give importance, so Sharad will announce when to start.
1 minute to go.
Yeah. That's why I said Sharad will announce.
टाइम कैसे रखेंगे इसको?
ऑटो टाइमर है ना आप लोगों का? बस ठीक है. कितना मिनट दे रहे हैं इनको? 4 minutes पर प्रेजेंटेशन. उसके बाद निकाल देंगे? नहीं क्या भैबू बजाएंगे कुछ? ठीक. कोलकाता एली एक बांग्ला चले रखो, सब बांग्ला बजा. Aditya meets me elsewhere also, but he doesn't see me in this.
Start.
I start. Good afternoon. Today I'll be talking about the prevalence of
timing rakho, sorry.
bacillary.
Shuru korechi.
I'll be talking about prevalence of bacillary layer detachment in diabetic macular edema and the response to anti-VEGF. So there are no financial disclosures. Bacillary layer consists of both the inner and the outer segment of the photoreceptor cells. The inner segments of the photoreceptors contain ellipsoid and the myoid zone on OCT. In 2018, Mehta et al. Introduced a new OCT-based terminology called bacillary layer detachment. So in this detachment, the bacillary layer is attached to the retinal pigment epithelium, whereas the remaining fragments of the split myoids, the external limiting membrane, as well as the anterior retinal structures detach and move anteriorly. So there are two main factors responsible for this: potential loose space within the photoreceptors and the hydrostatic force from the choroid. The aim is to determine the prevalence of bacillary layer detachment in diabetic macular edema and its clinical response to treatment with intravitreal injection of anti-VEGF. It was a hospital-based prospective observational study done among 33 patients of diabetic macular edema who underwent a treatment with 1 dose of intravitreal injection, followed up for 2 months and then treated on PRN basis. All eyes were divided into 3 groups. The SRF only group had SRF but no Ballard, and the Ballard group had both SRF and Ballard, and the group that had neither SRF or Ballard. The results: 33 eyes of the 28 patients presenting with DME were included. Mean age was 59 years. Mean BCVA was 1.06 logMAR. Mean CMT was 898. These are some of the pictures showing the features of SRF with Ballard in DME before treatment and the OCT of after treatment, or 2 months after treatment. And this is the OCT showing features of SRF only in DME before treatment of the same eye 2 months after treatment. So the total distribution of patients based on the OCT finding: 51% had only SRF, only 10% had SRF with Ballard. The results: a significant increase in the baseline CMT in the SRF group was observed versus SRF with Ballard versus no SRF or Ballard. So the eyes with Ballard tended to have the worst baseline visual acuity and showed the least improvement after treatment. Ballard was present in 9% of eyes presenting with DME along with SRF. Only SRF was present in 51%, and neither SRF nor Ballard was present in 39%. Total resolution of Ballard was noted after anti-VEGF, along with a significant decrease in CMT in both SRF only group and no SRF Ballard group. But slight increase in mean CMT in Ballard group was observed, which was not statistically significant. The mechanism is yet to be determined. According to Kohli et al., inflammatory, infiltrative, or ischemic conditions of choroid reduce the perfusion of the outer retinal layers and RPE, altering the balance in the retina, resulting in splitting of ellipsoid zone and the myoid zone. So according to Chang et al., with anti-VEGF therapy, total resolution of Ballard and a significant decrease in CFT can be obtained and showed the most improvement in BCVA. But our study suggests that even after resolution of Ballard and slight decrease in CMT showed worse visual outcome after treatment. So to conclude, our study suggests that Ballard was observed in 9% of the eyes presenting with DME and showed poor outcome functionally and structurally after treatment with injection anti-VEGF. The limitation of our study includes failure to consider central foveal perfusion parameters to account for the choroidal ischemic component and the exclusion of choroidal thickness measurement, which may play a role in the pathogenesis of Ballard in DME. Further studies with larger sample size and wider inclusion of parameters to measure the perfusion and the choroid is required to ascertain the reliability of Ballard as a significant biomarker. These are my references. Thank you.
So, so nice concepts. How long was the follow-up?
3 months, sir.
3 months.
3 months.
Do you think it's long enough to consider?
It has to be longer, 6
Okay,
months.
because as it is Ballard is sorry, not specific to DME only, but across
Yes,
many inflammatory disorders, infiltrative, as you know.
Yes, sir.
So, of course, few OCT pictures didn't typically showed Ballard with
Ballard. Yes, so
uh,
there were 3 groups with only SRF group and SRF with Ballard and no SRF or Ballard.
How do you differentiate? Sometimes it confuses with the outer retinal tubulations.
Yes, sir. But with SRF only group, they did not have, like, if we look at the edges of the edema, we can make out this thing. So they will be curved, and you can actually see the splitting at the photoreceptor layer. But in SRF only group, that splitting will
What
not be
was the
able to,
OCT that you
irregularities
used?
will be there.
Swept source?
Sir?
The OCT was swept source?
No, SD OCT.
SD, spectral tube.
Yes, sir.
Anything to?
Like, is there any recurrence? You have followed up all the patients for 3 months.
Yes.
What is the recurrence rate of bacillary layer detachment?
Recurrence, we did not see.
Now, if it is getting subsided, then again it recurs within 3 months, or you have to do more follow-up.
Yes,
for
sir.
the
We
recurrence
need longer
yes,
follow-up
longer
to see
follow-up is
whether
necessary.
recurrence was there.
Thank you.
Basically, it is a chronic inflammatory disease, so it is very difficult to conclude in 3 months follow-up.
Yes, sir.
Absolutely.
Sometimes it is very difficult to identify Ballard in presence of exudation and edema. Did you have any difficulty in identifying them?
There were difficulty to identify it, but not in DME, sir. We've also done a study where there is Ballard in posterior uveitis, and which is also seen in weakage. So in those conditions, it was difficult to diagnose. But in DME, the cases who had Ballard, we could easily identify. With the cases who had only SRF.
But Ballard, as all of us share the same view, that it is not very specific marker, biomarker. It cuts across spectrum of many various disorders.
Yes.
So anyway, but the concept that you try to make, good effort. Please come.